Okay. Good afternoon. Thank you so much for coming in. As I said, my name is Kaushik Loud, and I'm here to talk about CardioSentinel. This is a company that has been
Which company? Cardio?
CardioSentinel. This is incorporated in India. We have active collaboration with Purdue University, United States, which is World Bank 3, MIT, Stanford, Purdue. We have also academic collaboration with the Telangana Institute of Technology in Vadana. So their chancellor, biomedical engineering team, computer science team is fully on board with us. And when we are implementing it here, their students will come and do it, installation, everything with you, and collaborate with the doctors. So the concept we're bringing in is that in India we have this very famous doctor, Dr. Chandrasekhar Patmore. He recently died in January 2026 of a STEMI heart attack. 3 days before his passing, his ECG showed everything was fine. The current crisis is that when patients come with a problem, it is an episodic view that the doctors are getting. At this particular situation, what is happening with the patient? And the fragmented data and the lost context indeed matter. Here is a condensed version of what it would look like. The disease progression, early cardiometabolic risk, weight gain, hypertension, progressing into diabetes diagnosis, increasing low density lipids, triglycerides, going on into early organ stress, liver function, kidney function, ECG abnormalities, and then going towards progressive cardio deterioration, increasing ischemic burden, reduced exercise tolerance, and finally, a STEMI event. And also the full picture is missing. Even if we get the healthcare systems with all the proper tests, everything else, we need to understand what the different biological factors, genetics, family history, circadian rhythms, those socioeconomic factors, physiological dynamics, environmental factors, they are not accounted for. Right now, when I've been to multiple hospitals in Mumbai, this is the scenario I'm seeing. In KEM, they're seeing 2 million patients a year. In JJ, they're seeing 1.6 million patients a year. That's average 5,000 to 6,000 patients a day. So it is extremely crowded. Doctors in India are superbly trained. They have a lot of talent, but if this is the amount of crowding and you have 20 seconds to 1 minute with a patient, do you have the ECG? Do you have the DVD from your past angiography? They might not even have it. So this is making the work difficult. And right now, what we have in Maharashtra is the ABHA Ayushman Bharat Health Account for having a health ID and other information, and HMIS, which is being currently implemented by MCGM in MCGM hospitals. It has been implemented up to a certain extent at KEM. I had opportunity to present to KEM to one section, some cardiology and some other departments. We have another review coming up with the academic dean, Amita Kavle, and the orthopedics, Dr. Mohan Desai, and everyone else. That is part 2 of the review process that's going to go over there. And we try to understand what is happening in HMIS right now in Maharashtra. So what we're seeing is that you have images, PDF, DICOM videos, texts. This is raw data. This is not exactly correlated over time. The intelligence has not been extracted over it. So if we were to look at how much of the data is, we did a complete study as to right now this is year 1, month 3 of HMIS. Okay? So when I'm being told that I'm able, by an assistant professor, that I'm able to see the ECG and the angiography on HMIS, that's great, but is that enough? An angiography DVD can be 500 to 1 gigabyte in size. Images take a lot of space. So we are very thorough, we did a complete research into India. We looked at AIMS data, we looked at AMI's Bhubaneswar, every conceivable Indian hospital amount of data that is used here. And we extrapolated that, this is all the references, we extrapolated that for the amount of data for a 2 million patient hospital, just KEM. Remember, this is not what a hospital in the United States or Europe would be doing. Their amount of data is much higher. They do a lot of other testing. This is just Indian data. Okay? So now if we measure that, and if we look at the raw data, so right now we're talking about per year 4,552 terabytes. And according to the law, enterprise storage has to be 3 times the amount of data. So that comes to That comes to 14 terabytes a year. Now, in the Maharashtra government HMIS official document, they're saying the amount of data that we will store is going to increase by 30% compounded annual growth rate. So if if you look at that, 14 petabytes per year becomes, let us assume that a cardiac patient will live at least 15 years, very conservative. You know, like a 50-year patient gets started onset of atherosclerosis or something, let's assume he'll live till 65, which is a very conservative number. Even with 15 years of age, 15 years of storage of data, that comes to 537.8 petabytes. That is the cost. By year 15, that is US dollars, $1.47 billion. Good afternoon, madam. You're trying So, we were talking about HMIS, and what we're saying is the amount of, if images are stored, right now the images are being stored with HMIS. So we did a study where an amount of data that would be required to store in just KEM hospital with 2 million patients a year, and these are our calculations. For year one, it is 13.66 petabytes. 1 petabyte is 1,000 terabytes. By year 15, assuming 15 years life of a person with an onset of cardiac disease, that's 537 petabytes. The cost for healthcare grade management storage, just the cloud server, is $1.47 billion. So I had some interest, so I did some digging when I went to HMIS at KEM, and I had some really interesting conversations there. So I spoke to the general manager at HMIS, KEM Hospital, BBC, like TV channel, BB Chaudhary. And what I said to him is that I would like 15 years at least of data for my mom, so that when doctors see it, they can see a health progression. He said, my mom is 85, I would like to see that too. So I was like, how much data do you think you'll require? He's like, hey, the cloud mein jana. Cloud is not free, right? There's a certain cost associated with it. So I was like, sir, can you assume how much it would cost for 15 years? His answer was very, very symbolic. Hamara contract 5 saal ka hai, uske andar hum kya देंगे? So here's a question that we have to ask ourselves. What are we going to do as doctors and technicians and patients? We have to look at that perspective. So right now, this is the number for one hospital, KEM. There are 10 to 15 major tertiary teaching hospitals in Mumbai, just Mumbai. 30 plus government hospitals, medical colleges, specialty peripheral hospitals. Entire public health network in Mumbai is 400 facilities. How much would that cost me for HMIS for Mumbai only? So let us say that, okay, fine, you want to store images? Let's go with images, okay? So they said images, we're going to compress the images, that's going to just take less storage space. By the way, a lot of these licenses are not available. Angiography license is not there. So you're not going to get angiography images. Can you imagine that for cardiac artery disease? So images are dumb data. They cannot be correlated to the health history, the medication, and other test results. If you're going on a trip to France, okay, and you say that hey, you know what, tell me some information about France. I give you a photograph of Eiffel Tower. Is that enough? Or would you like an interactive map where you have all the different locations, cost of the airfare, how to travel, safety, weather, all that information? What is of more value? The picture of Eiffel Tower or the interactive map? So that is the difference between image only versus CardioSentinel. So they're saying that we can compress the images. But the question is image compression even allowed in other countries? And what is the law in India for image compression? If tomorrow, as you're making a decision on cardiac surgery for stent placement, you want to see the size of the lesion, the percentage of stenosis on the left arterial descending artery of the heart, and if you're not able to see that clearly, if the image resolution is not enough, how are you going to make a judgment call? Regulatory status of medical compression data in India. India, which is not actually a surprise, India has no binding law or technical regulations specifying compression methods. regarding compression methods, minimum image quality, or mandatory lossless storage for diagnostic medical images. We are an American company. We're not going to make statements without being 100% sure of this. So the DPDP Act 2023 focuses on privacy, consent, and data protection. No provisions for image fidelity or compression. The Ministry of Health and Family Welfare EHR Standards 2016 recommends DICOM, but does not mandate lossless compression or set any quality thresholds. These are advisory, not enforceable. In the United States, whenever we are doing any medical device products, we are going through the FDA regulatory process. FDA officers are coming in and checking on us. If we make a mistake, they're shutting us down. Here, it is not enforceable. These are suggestions. It's kind of like, anyway. ABDM emphasizes interoperability for health, HL7, etc. It is absolutely silent on image compression, diagnostic quality. DICOM PACS, it is a standard. It allows both lossless and lossy compression at your discretion. Tomorrow, if there's a misdiagnosis and you say the image quality was not good, you go to court, they're going to say, the doctors never told us what image quality they want. You want that on your heads? The conclusion, current regulations address privacy, interoperability, and general quality processes, but do not enforce technical standards. So let's, I'm going to jump a bit ahead. I'm going to show you what I'm talking about. So this is an angiography image. This is your raw image to your left-hand side, okay? The middle is the compressed JPEG image. So my question to you is that if we look at, below over here, the stenosis estimation, the lesion length, the reference diameter, diagnostic confidence. If you look at all the information, the high-quality diagnostic image versus the lossy compression, can you tell me if the compressed image is good quality for enough for diagnosis? And right now, what we're showing on the right-hand side is what we are doing in collaboration with Purdue and with NVDIA, which is called MONAI and CATHI. This is what it looks like. This is going to take 90% less data to store, and it is going to look at the amount of clarity you have. We have mapped out the entire cardiac artery tree. We have showed you the lesion size. And tomorrow, if the head of department or Professor Moore is not there, if there are junior doctors involved, they want to see something, they can see this, and this information is in front of them. So the question is it high quality? We have 80 pages of data from hospitals such as Harvard, UPenn, Johns Hopkins, and all the major hospitals and universities in the United States, authenticating the quality of these images, everything else. You're seeing everything clearly, it is mapped out. And this is taking 90% less storage space. This is the difference between image compression and image digitization. This is the difference, like if you take a picture and you want to use it as a wallpaper on your laptop, if you compress it, if it's JPEG, the image quality suffers. Digitization is like taking a magnetic tape and converting that into a CD. Quality improves. So, madam, I was just talking about like an image compression versus digitization. So, if we're taking an image and compressing it, okay, so the image quality suffers over here. There's not enough clarity. But if we are using digitization techniques, we're able to highlight everything, and the quality does not suffer. The doctor's ability to discern the information does not suffer. So, so the questions that we have to ask as medical device engineers and doctors and administrators is, what is the scale and sustainability for HMIS in its current form? Can we do it for 15, 20 years of patient data? With, for example, 2 million visits per year, KEM, and...
So I have a query.
Yes.
Two queries. What is the data or KM you have shown? KM means Maharashtra's KM and JJ. Both are Maharashtra's high volume referring centers. The patients coming to KM and JJ are from all over the parts of Maharashtra, plus some parts of the India for KM and JJ. So maybe 2 million, what the something figure you gave. I'm just discussing. It's not applicable to all other hospitals.
Absolutely correct.
Other hospitals, maybe other 3 hospitals, Sion, Nayan, and Upper, whatever may be there, maybe all three together maybe up to KM or maybe.
SAN has around 1.4 million because I represented at SAN. We know Dean England,
Okay.
and we work with Dr. Nathani, so it's around
Yeah.
1.4 million or something.
Okay.
JJ is 1.6.
No, I'm telling KM and JJ may be nearly the same. KM may be because these are tertiary means.
Very big hospitals.
And these are Maharashtra's one of the best and reputed hospitals, which are considered as one of the final authority.
Reference center.
Final referral center means Cooper can also be a referral center, but one of final referral centers for at least lower middle class people or few people who do not want to go to private. Second thing, yes, not to contradict, whatever the decision or about that is, I definitely appreciate your this thing about image quality and all that. But generally, we do not take any decision about angioplasty or this thing without looking the CD in the, though it may take 5-10 minutes more time or 3-4 minutes more time. We do not take any decision till we are able to get any good quality image. Either we, if the angiography is done at our center or nearby center, we see the, if it is done in our center, we do have available angiography, this thing, what we say, images.
The DVD is in front of you, put it in the computer, you see it,
Yeah.
you confirm it, then you do it.
Yeah, if it is done at other center, other hospital, till we reload the CD and then we see the images. Even at few peripheral centers, they may not have good cath lab. If we are not happy with the image quality,
You get it done again.
we may ask sometimes. This happens rarely, but
So what you're saying is perfectly right, Dr. More, and thank you for bringing it up, and that ties up with our vision completely. And we have no points to argue, that is perfect.
yeah, I'm discussing.
No, I agree with you, and I'm going to be able to address those concerns in the subsequent slides. So what CardioSentinel would do is that it would eliminate the need for you to run a second test or to have the DVD put in. We have such technology.
We need second test because the fault is in primary problem. Some cath labs are not in periphery.
They're not doing a good job.
In periphery, few cath labs.
Mhm.
Either sometimes it may be operator problem, sometimes it may be the machine problem. Operator, if some junior is doing, he may not be get selective images.
Correct.
We are not happy with the image quality. कि बाबा lesion ही पता नहीं चलता. I cannot give the plan. This happens, not frequently, but this thing in practice or in real world scenario, these things happen. Even at KM also, at some district level hospital, angio has been done, maybe done by some junior cardiologist or maybe not done at this thing. So you are not able to see, give exact what is the percentage of lesion and all that. In that case, we advise either you get second angio done or this thing. It is not because of software problem, it is because of intrinsic problem.
डॉक्टर मूर्ती मी जे म्हणताय मी कम्प्लिटली तुमच्याशी एग्री करतो, परंतु ते लेवल ऑफ स्किल आणि ट्रेनिंग जे आहे ते कॅथलॅब मध्ये ते आमच्या कंट्रोल मध्ये कंट्रोल मध्ये एकदम असतं.
I'm telling you,
नाही मला समजतं.
every decision we take by looking the CD in our this thing, console.
I understand, but what I'm saying is that is an additional burden on you.
It takes 5-10 minutes, but
Yeah, I understand.
that time needs to be given.
Yeah, so what I'm saying is I understand that. So the point, Dr. Khare, is that in Maharashtra right now or India right now, there is for example, the HMIS, if we're storing images onto the servers and if we are transporting that back to the clinician's laptop or the computer for them to see the status of the patient, this images will take a lot of data, very large size images. So when we had a conversation with HMIS in KEM, the response we got is that we have a cloud and we can store all the data in the cloud. And in KEM, they have a 48 terabyte in-house server and a 24 terabyte backup server. वो एक दिन के लिए काफी है. And she prepared like हमको परवाह नहीं है, वो तो cloud में चला जाता. So the thing is, cloud is not something necessary. There's a lot of cost associated. So how much is the cost? If a cardiac patient lives for 15 years, how much of the data are you going to store there? So their response is, we're responsible for 5 years of the contract, we don't care. So right now, they also said one thing, that we're compressing the images. So when we looked at the Indian laws for image compression, we found out there is current regulations address privacy, interoperability, and general quality processes. They do not enforce technical standards for preserving diagnostic fidelity in compressed medical images. So this brings to our next point. This is, for example, an angiography. This is the proper original high-resolution angiography image to your left-hand side. This is a compressed JPEG. So you can see that, this is not very clear. This is, on the other hand, the right-hand side, our advanced Aurora interartificial intelligence for understanding the image on the left. And this takes 90% less storage space to store it. And because we are extracting the intelligence from it, the diagnostic information over here is coming from the doctor. Here, with our software, we are identifying the diagnostic information and linking it across the entire platform for different medical parameters.
Why this AI powered image takes minutes?
I will come to that. So now, what Dr. More said is that, yes, sometimes image quality might not be good at a certain cath lab. We will have them redo the image, which is completely justified. And we cannot address that, the quality of the skills of the cath lab. We can't address that. So having said that, the other question is, if we are seeing in KEM 2 million patients a year, which is a very large hospital, as Dr. More correctly said, JJ6 1.6 million, LTNB6 1.2 to 1.3 million. I don't know, I've not looked up the Cooper. But even if we conservatively look at it, because we have right now in Maharashtra 15 major tertiary hospitals, 30 government hospitals, medical college, general specialty, and 400 facilities across Mumbai, just Mumbai, not Maharashtra. So if we look at that amount of data, and if KEM is generating 500 terabytes of data, 537.82 in year 15, how much do you think it will be requiring for all, even 30 hospitals in Mumbai? Okay, so it will be very huge, the cost will be preventatively high, and if you're storing images, how much time will it take for the data to come from the server to your computer? Are you going to be able to process it? How much server do you need in your hospital to be able to process that data? What processing power do you need? These are valid questions. Right now, this is month 3 of HMIS. Having said that, data governance, how long are you going to retain the records of the patient? There is no, when you decide that the data is going to be deleted, what is the total cost of ownership? Has this financial model been independently evaluated? According to our research, no. So right now, what CardioSentinel does is, this is our main pitch. We are take patient care, collecting all the different modalities of the testing, blood test, ECG, imaging, CT, MRI, X-ray, angiography, other tests, storage reduction up to 90% using advanced AI paradigms, and I will be explaining those to you, and I'll be showing you how we're doing it. And then it will take less data storage space, and using advanced recreation techniques, we are able to recreate those images with 98.4% fidelity to the original images. And because of the less amount of storage space, and because of connecting across multiple tests and everything else, you are getting a clear picture of the patient health on your screen with limited processing power. So how can we actually do it? First and foremost, each hospital identifies the different protocol-driven screening for the chronic conditions, atherosclerosis, diabetes, hypertension. You guys decide what tests, everything else the patient needs. You guys go into a structured diagnostic input with time follow-ups. We have apps which the patient's phone will have, and they will give a warning. According to your disease, this is the test that you need to do, this is the timeline in which you need to do it, this is your alert, you need to go ahead and do it. So for medicine, you guys are the front line, right? Because even if a person has a cardiac problem, he's not going to go to a specialty, he's going to come to medicine. So you would see, you would do the general medicine evaluation, do the clinical assessment, understand the history and examination, the risk factors, order the investigations, blood test, ECG, imaging, whatever be that. That would come to the CardioSentinel for processing. And once you guys decide that, hey, this is actually a cardiac incident and needs to be referred, you guys refer to cardiology, and the data remains in Cooper Hospital, in HMIS, and it goes to cardiology for easy consideration. Pulmonology, the heart and lung function is one organ system, essentially. So the longitudinal monitoring over a number of years is very important, like COPD, exacerbations, lung function decline, interstitial lung disease, fibrosis progression, oxygen dependency. In India especially, tuberculosis is a big problem. The treatment response time is 6 to 24 months. And you need to do, like, understand the fibrillary remodeling, chronic impairment, cardiac effects of prolonged inflammation, bronchiectasis, recurrent infections, structural deterioration, pulmonary hypertension, sleep apnea. And essentially, as the heart and lungs, left ventricular dysfunction of the heart will lead to pulmonary congestion and breathlessness. Right ventricular dysfunction will lead to, again, pulmonary hypertension, called pulmonale, chronic lung disease, chronic hypoxia, cardiac remodeling, and arrhythmia. So these are very correlated diseases, and again, having the longitudinal data is of great significance to you. Now going into how exactly we are giving you the 90% compression and the 98% recreation. Let's take a look at every cardiac investigation begins with physiology. Physiology begins with ECG. Sorry. Good stuff. Anyway, so I'm going to go to this slide because this is my raw data slide. So let us take a look at some ECGs, okay? This is a standard 12-vector ECG, right? The amount of data at this ECG is excessive because of a lot of the noise and the wander. Noise. If you take a picture and try to store it, it will take a lot of storage space. If you convert this directly into digitized model, it will take a lot of storage space. Another, original ECG signal with noise, filtered ECG. Noisy, filtered. Baseline wander, up and down, removed with our algorithms. Again, original signal has all the noise, band pass filter, filtering, clean ECG signal versus motion artifact. So, going back to our original presentation. So this system will reduce your workload. You do not have to go to a computer and manually enter anything. It is all automated. So the patient over here to the left-hand side is connected to the 12-lead ECG machine. The ECG machine gets the ECG. Using our algorithms, we will extract the data. The raw noise in the bottom, you see raw noise ECG, will filter it. We will do the peak detection. And we will identify each heartbeat. We will take 15 samples per heartbeat. And look, this is a clearer picture of that. ECG refinement. This explains all the different algorithms which are used over here. So they will be doing step-by-step filtration, bandpass filtering, baseline correction, noise reduction, standardization, final refined ECG. This is how we are reducing a ton of data size. We're removing the extraneous, non-essential elements. Now, is this good enough? Digitization of ECG has been there since 1971. It was done first at Utrecht Medical College, Netherlands. It is a 56-year-old technology. It is very mature. Like I said, we have 86 pages worth of references that we will give to you to validate our claims. So we for every heartbeat, we identify the R waves. We take 15 samples per beat. And instead of taking 60,000 data points, we require 6,000 data points. This is not compression. Image compression means you reduce the quality. We are not reducing quality. We are digitizing. And as a consequence of that, ingestion and denoising, and these are the different sources: 12-lead ECG, Holter monitor, ICU telemetry, PPG signal, ICD device data. All the data, we're denoising it. We are using our algorithms to get detect the R peaks. Fiducial mapping is being done to identify the P wave polarity, T wave polarity, QRS duration, bundle branch ventricular widening, ST segment, elevation, depression, amplitude interval measurements, ectopic beat handling, and we are giving you rhythm characterization, ischemic markers, conduction anomalies, anomalous beat fingerprints, longitudinal indexing. So this is not just a picture, like we said initially, the difference between a picture of an Eiffel Tower versus an interactive map. And this is the advantage. Instead of using 5.2 megabytes For a raw ECG, for 10 seconds, you require 50 kilobytes. This is the amount of dust storage that you guys need. And the advantage, like I said, we're taking 90% less size and we are recreating the ECG with 98.4% correlation. Guaranteed. And we are linking every data packet is timestamped and linked to patient's medication log and health history. For example, medication, Metropol, beta blocker, whatever be that. So let's take a look how it exactly looks. So in a hospital, if a patient comes in and the ECG, if this is the ECG of the patient, the doctor will say, hey, there's an ectopic beat, and over here, the third beat. So that's a problem. The QR signal is, the duration is much longer, 148 milliseconds. But with our algorithms, you see we're raising a red flag and saying, hey guys, relax. He's on beta blockers. So that is not out of the ordinary. So again, instead of simple data interpolation, the skeleton utilizes structured, multidimensional vectors, a clinical skeleton forcing diagnostic accuracy. There is no hallucination of any of the data. Constrained cubic spine interpolation is an advanced technology. Our reconstruction algorithm is constrained by the stored polarity and duration vectors. If the vector says T wave is negative, the spline interpolation is forced to draw an inversion, preventing diagnostic hallucination. We do not fabricate data, we stick to the original. As a consequence, the amount of, instead of saving raw data, the processed data takes 90% reduction in storage space, and we are recreating that with 98.4% accuracy. You can even have like an old ECG on a paper, and we can still convert it into a digitized format, and convert that and integrate it into CardioSentinel. Let's take a look at angiography. One second. So this is what has gotten the most amount of excitement from the doctors in different hospitals. The angiogram shows the lesion, the longitudinal intelligence shows the disease. We have advanced algorithms from NVIDIA called MONA and CATHI, which we're using. This is a typical setup. You have an angiography machine. We do not require any infrastructure costs in your hospital at all. You have your angiograph cath lab system. You have your computer, which is pulling up the data. We install the libraries in your computer. These identify the different parameters of the DICOM image, and that goes to your HMI system. And as a result of that, again, it is all automated. There's nothing manual for you guys. So MONA and CATHI in action. Let's take a look at how it looks. This is your raw coronary angiogram. We're using artificial intelligence. We highlight the different blood vessels. We segment the coronary tree. We quantify the stenosis and the lesion size. So the coronary disease is it's not a snapshot of that particular day. It's a longitudinal story over how many years has the problem been progressing, understanding it. Our friends in Mayo Clinic and Cedars-Sinai, they're saying that they're moving away from angioplasty and stent placement just as a preventative measure and doing it only for like a sudden event like a heart attack, because they believe that a stent is not like a magic thing that's going to be there forever. If the patient is abusing his lifestyle choices, his eating habits. So it is better that even if the patient has 75% of blockage in his left arterial descending artery or some other place, with lifestyle choices, with food choices, with cardiac rehabilitation exercises and medication, he can reverse it up to 15 to 20%. So that is the way disease is progressing in these countries. Am I saying something wrong?
There is no data that says that a plaque can be reversed by 15 to 20%, unless and until a patient is on statin, a high dose of statin.
Yeah.
Again, exactly. Even with high dose of statin, the trials that have come, the statin trial and the yellow trial, these trials also say that a particular amount or a particular volume of patients, they can be reversed. Like
Very
every
true.
patient with a 75% plaque, you can't say that person can be on medical line of management. Because the recent guidance that says, the QFR or the FFR, that says that the myocardial distance to the lesion is not been supplied.
So the thing is like,
Again,
I'm saying,
this is what am I saying, for the mortality benefit of the patient and the symptomatic benefit of the patient, he needs to be stated as of current guidelines, I'm saying.
Mm.
Okay, so reversibility may happen or may not happen, and reversibility may not happen overnight. Reversibility would take somewhere, at least a year or two to happen. Because again, plaque formation, that 75% also has not happened overnight.
It took
It's taken
decades to happen.
decades.
Yeah, exactly. So, and thank you for saying that. I am not a doctor, I'm a biomedical
No,
engineer.
I'm just saying.
I agree with you. And the thing is, like, again, this is your judgment call to make, not mine. What I'm saying is that, like you very correctly said, it is happening over multiple decades. And after, like you were saying, 75%, and you're imposing certain medications, certain lifestyle choices, certain exercise parameters on the patient to be able to understand how the progression is happening, you will need the longitudinal data to review how the things are. And that's where we come in and we give you the angiography. Okay? So let us take like a hypothetical situation of how exactly the patient's angiography looks over multiple years. Like this is, for example, this is of course like hypothetical, like the progression is 30% to 45%, that doesn't happen in normal life. But this gives an illustration as to what it would look like. So you're seeing like with all the images present in front of you at the same time, instead of popping multiple DVDs on the computer to take a look at year X, year Y, year Z, you have it all in front of you. And this is what it would actually look like. This is MONI and CATHI in action. Can you imagine that tomorrow, if you don't have senior level doctors in the clinic to make a judgment call, if there's a junior doctor handling the situations, having this would make his life so much easier. And the ability to take a look at everything very clearly over multiple years. This is the latest and greatest in terms of medical technology, which is right now being created and included in major hospitals.
This is an example, or
This is an example.
This is an example. Like this is not something which is
No.
no. This is not explaining. Like this is just an example.
Just an example of how it looks like, yes.
Because again, like the vessel that's been demarcated by the AI is not appropriate. That is the reason I'm asking you.
This is an example.
Just an example.
Exactly.
Right?
We do, because patient laws will prevent us from getting actual patient data.
This is just an example that we're portraying. Okay.
So again, going back to the previous image of like what it would look like. And so having all this information, what does it look like for the doctor? So right now when a patient comes in, he has to buy the 10 rupees Kapauti and then basically stand in line, get the paperwork for the different departments and then go to the doctor's office, stand in line. And then he will have to have his like file with all the reports and it comes in front of the doctor. So instead of doing all that, the patient uses his app at home to register himself for a visit at Cooper Hospital. And he decides to come in and he goes to the computer at the entrance and he scans his QR code. And on the doctor, for example, we have 10 patients or so coming in the cardiology department. We have all the patients' names entered on the left-hand side. Rajesh Sharma, Suresh Iyer, etc. And Jai Jagannath is your patient right now. And you have this wheel in front of you for ECG, angiography, lab results, medications, lifestyle and behavior, all this information in front of you. And you're able to click, for example, on the blood test results and see how exactly it is progressing for him. Like, his HbA1c over from 2022 to 2026. In 2024, he decided to be on metformin, vildagliptin, glimepiride, and it started coming down. In 2025, he started taking lifestyle changes. It came down further, which is a good thing. Similarly, we take a look at lipid profile. It is escalating without any check. Kidney function is again going up, but then it is being brought under control in 2025. You see the medications he's taking and the timeline in which he's taking it, what is working, what is not working. And after that, the ECG for over multiple years, 2021 to 2026, you have the multiple ECGs in front of you. You click on an ECG. I have a working app actually. If you click on the ECG, you can see a full version of that on your computer. So having the multiple year ECG, everything in front of you is amazing. And then of course, like what I showed before, with the vascular intelligence of angiography over multiple years. And again, this is going to be used in the United States and Europe also, not only in India. So we are going to adhere to 21 CFR Code of Federal Regulations 820 from the United States, ISO 13485, which is the same as that in the European Union, and ISO 49, all the standards. We are going to have very strict usability rules in place to understand how the doctors, nurses, and the patients want to see it, how easy it is going to be for you guys to use it. So we're not going to force anything on you. Make sure that we understand that failures happen because of three reasons. design manufacturing flaws, inadequate training, and real world stress. You guys are working in very high stress environments. We understand that. We want to make it as intuitive as it is for you guys. And based on that, we're going to design that. We're going to have the front-end research, contextual inquiry in real-life environments, iterative prototyping with your feedback, and design refinement and optimization for the final design outcome. Finally, patient privacy and data protection is of very big importance to us. The United States and the European Union have very strict laws, and also India created a lot of laws in 2023, the DPDP Act and everything else. We're going to adhere to everything else. And we have also a collaboration with NVDIA, and so they have something called the recent confidential computing architecture by which patient privacy is hardware protected. And this is phase one. Phase one essentially gives you a longitudinal engine to look at patient data over multiple years, okay, like we showed to you. And this makes diagnosis and treatment much more easier. Phase two is what is of great interest to American and European companies because a lot of them have the phase one already in place. So in phase two, essentially, we're doing predictive modeling and decision support. So with the multimodal longitudinal inputs coming in from different departments and all the data over a couple of years, we have the structured longitudinal feature graph for different patients. And then we will be using that to train artificial intelligence models which will create predictive insights and clinical decision support for the future. So what exactly am I talking about? So let us say that we understand the subtle changes over time. Okay, when we detect the hidden convergence factors, like if we're looking at maybe 30 million patients all across India, United States, and European Union, and we understand how exactly their electric instability, hemodynamic stress, and everything else is happening, based on that, we create a predicted physiological deterioration trajectory. So to understand this is the main part, the last part. So this is what it would look like for a patient who's we are seeing that we are identifying, it's a bit hard to read, like the ECG morphology, the HRV, the lipid profile, EGFR, liver function, troponin, and then we're looking at the angiography, lifestyle behavior. And based on that, we're giving him risk scores, and we are understanding the trajectory of his health. And this is being done in correlation for over 30 to 40 million patients worldwide. And thus, we are able to predict that, hey, you know what, buddy, you're standing right now in Q2 of 2026, this is where you stand. Your risk is not that high, but if you do not change things, in Q4 of 2028, we see a very catastrophic heart attack event for you. And these are the medications that you take, which are actually working for you, and you can take them and do the lifestyle choices and prevent the event. So what does this do? In the United States, what we saw is that having a heart attack or a catastrophic event not only affects the patient, but also the entire family. Okay, and a lot of the cost is being borne by the government, right? So, and of course, insurance companies. So preventing an episode from happening, everybody wins. Phase two, the predictive physiological deterioration modeling. We do the early intervention model, act before the event occurs, risk review, intervention by social workers, therapeutic optimization, closer follow-up monitoring, and the clinical impact is measurable and meaningful. We have a 12 to 18 month window before the episode happens, before something dangerous happens. We reduce the number of cardiac events by 30 to 50%. We utilize the resources in our overstretched hospitals significantly better, and we are able to personalize the care for the patient and give them better outcomes. And this is again going to be done in a completely privacy-preserved AI infrastructure. We're going to adhere to every single law in India and abroad. And in this 24-month journey, if we're able to do the multimodal data pipelines, the phase one and then the phase two, if we're able to complete the research in India, it would propel India as a global leader in this sector. So I am getting, when I'm doing this research right now, because my father was a decorated officer in the Indian Navy. He fought in 1971 Operation Trident, which was the attack on Karachi. I don't know if you've heard of that or not. My grandfather was a freedom fighter, and so I want to do something for India, and when I'm pitching this idea, I'm being told in Purdue and other places that we have curated data sets available from MIT and Stanford. Why don't you use them? But the reason I want to do it in India is because, number one, the amount of data that you're using to train an AI system determines the success of the AI system. No other country has a population like India does. Number two, this is Indian physiology is distinct from the physiology of other people. Okay? So creating something for my people, South Asian people, my Hindu people, whatever be that, it is something I want to do. Okay? So in spite of having pushback, I'm bringing it here and I'm trying to work with you guys. All I want, from you guys is to take a look at it. If you feel that this is something that we are not looking to replace any of your systems, we are not looking to sell you anything. The algorithms, whatever be that will be given free of cost to you. Our expertise from professors at Purdue, scientists such as myself, and professors who are not only doctors but also biomedical engineering professors, they will be working, and the Vidyalankar Institute of Technology Engineering students and professors will be coming in, will be giving it, will be installing it over here, and all we want is essentially tell us what you think about it, and if you want, then later on, collect the data and let us do our AI system. If you approve it, then we will do that, and this will be an active collaboration, and this will help our people. If you have any questions, I'm happy to answer them for you.
Basically, the HMIs that we have at the moment, this is going to be collaboration with them or what?
So essentially, HMIs and ABHA, whatever you have, that's great. But like, for example, you have an Android phone, and in the Android phone, you have an operating system and some basic system level things provided by the manufacturer. But then you download a lot of apps to make your life easier. So CardioSentinel is essentially something like that. Instead of using bulky raw data without processing, like with the best example I gave you, the Eiffel Tower picture when you went to France, and when you saw the Jai Jagannath screen, blood test results, everything, and not images, but clickable data. I haven't, this is recording right now, but I have an app. You click on the blood test result, you click on the HbA1c, you click on that, you'll be able to see it over multiple years. You'll be able to see why did it fall over here, the medication that came over here. You see the ECG, like I showed you, if there is an aberration, ectopic rate, why is that happening? The patient is on a certain medication. This level of in-depth deep dive, you do not have access to that. And we give that with our system. This sits on top of HMIS and reduces and makes everything used. Essentially, we have these, you can say it is application-based, it would be sitting on your computers, like we showed you this case, with the ECG machine in your lab, the ECG is being taken, you have a computer where the ECG is being collected. The libraries are placed over there, our libraries. These libraries digitize the ECG data, and then it sends it to instead of raw images, it sends it to the HMIS.
Basically, the ECG that we take in our day-to-day practice, this should be something which should be an electronic kind of a thing.
Digitized version, yes. Angiography, ECG, MRI, images, whatever you have. And also your blood test results, everything else. This will all be connected over time.
They like in corporate hospitals, like they have, these database of a
Can you repeat the first part?
like in the corporate hospitals, they have, the data of a particular patient, like over the years, if the patient has been with the same hospital. Like for example, if you go to HML land, so they have their own system. So if you enter the patient detail, you get everything, the medication the patient's been on, the investigations that have been done over
It would,
years.
yeah, but then again,
Again, that's not the AI.
that's raw data.
Raw data.
Photographs, images. This is processed data. So you can click on things, go from here to there, correlated.
Okay.
A doctor in medicine can relate to a doctor in cardiology and say, hey, you know what, I saw this patient, it doesn't look right to me, take a look at this. And he said, hey, you know what, this looks okay. No, he's on this particular med and this is how it's reacting. You can click to the different modules and you can go a deep dive using just the data.
So we all have access to it.
Yes. And like I said, like all these things, the Moonlight, the CAT, everything else, we have collaborations with NVIDIA and everything else. And we'll give it to you for free.
So as of now, it is for cardiology.
It is for multiple departments. I mean, Dr. Amita Table of pulmonary disease, right? She has shown a very high interest in this, and the doctor can attest, the longitudinal view for pulmonology is just as efficacious for cardiology. When we started CardioSentinel, and that's why I named it CardioSentinel, was primarily focused on cardiology. But as it has progressed, I'm getting feedback from multiple departments saying that this has wide application here, and correlating it to medicine and pulmonology along with cardiology makes a lot of sense, and that's why I asked these two departments to be here.
These three go hand in hand.
Yes, that is the reason why I asked them to be here.
Okay, because anything that's pertaining to cardiology, patient may have some of the other pulmonary factors associated with it, and medicine is only in the mother branch. So, but then the point is other departments, other than medicine.
So this is a question of and this is a very valid question, and Dr. Mohan Desai, medical superintendent KM, he is interested in knowing things from perspective orthopedics because we do have algorithms in place which can also look at x-rays and things like that. But that is going to be like an additional effort on our part to be able to go out there and do it. Can we do it? Like if that means that if we are able to get in the good books of a major hospital like KEM by doing that, we will make the effort to do that. We will basically assign our students and scientists to do the research and give it to you guys. Ultimately, our objective at the end of 2 years is that we want, my objective is to predict cardiovascular catastrophic events 12 to 18 months before it happens, before a heart failure happens, before a stroke happens, before something devastating happens. And that is what Karolinska Institute in Sweden, Mayo Clinic in Minnesota, Santa Rishka's hospital in Lithuania. We had a doctor from NHS actually come to our presentation at JJ Hospital. NHS in the UK have showing them out of it. It's the predictive part of it. But the phase 1 is something that I had not even anticipated. I thought I could just walk in and do phase 2. But then I got pushback saying that we just don't have the resources in place to do phase 2. For you to get the data, you have to create the data. So this is where I'm coming from, and I'm requesting you with folded hands. I am from here. I was born here. I'm not from someone from outside. I'm doing this for our people. I request you for a very, your honest opinion. Let me know, and that is all I ask from you. If you guys think it is good, let me know. If you see any problems, let me know. And we will take it to the decision makers. We'll take it from there. But what is your take on this, by the way? What is your take on this, doctor?
So it's a good, whatever your CardioSentinel is. See, when we are looking at whatever it is, we should have a longitudinal data. So when we are collecting a longitudinal data, I should have those patients who are following with me on my institute, wherever the software is there. Okay, so that I can have a longitudinal data. Now the point is, how many patients in the OPD that I see are on a regular follow-up and they are following my OPD. So I can have a certain data. Let's say, from my point, let's say a patient of COPD who has now started showing symptoms of COPD. Okay, what is the grade of COPD severity? Okay, over a period, what is going to happen to that patient if he follows up regularly with me? And the cardiac events that will happen because smoking, the risk factor is the same, probably. So if that patient follows up regularly, then I can have a longitudinal data for that patient. In Mumbai, do we have that? Because with floating population, okay, whether I can have that much of data. So we need to see into that, whether those patients will be following up regularly with my
That is an excellent point. And actually, from the research we did, when we talked to Dr. Chaurasia of Nair and Dr. Kalyan Mode of JJ and everything else, what he said is that, because pulmonology and cardiology are such, pardon me for saying this, scary fields of medicine, and if they build a trust and relation with the doctor, they stick with the doctor. And if Mumbai-wise or Maharashtra-wise, we have an HMIS system in place, that it doesn't matter where he gets the test result. It can be in it can be in JJ, it can be in KEM, it can be in Uber, but they will all come in the universal HMIS, and it will be made available to you as a main treatment physician. And we are going to do that when it comes to you. Our objective is we are not the kind of people who cut corners. You have to understand, when I was telling you about, I'm the co-inventor of the world's first heart attack metabolic intervention system called Merlin Mobile. So when a heart attack is happening, when a blockage is there in the cardiac artery, and you have to have a surgery done within a certain amount of time to prevent infarction, myocardial infarction, time is of essence, right? So the pacemaker has to be able to communicate with the phone. We literally made a phone with Flextronics in Monza, Italy, to do that. So the question is, in the United States, we have a law saying that the battery of a pacemaker has to last a minimum of 10 years. So the first step, Eric Train was the CEO of St. Jude Medical. He ordered me, show me a budget of the battery that in spite of having your tomfoolery, whatever you're doing, that's not going to drain the battery. So the first step I did was to create a complete list of the power consumption paradigms, and I said, I'm sorry, I can't do this. It's going to drain the battery significantly more. So he said, we can't do that. Because ultimately, this has to be patient-centric. We are a biomedical company. We need therapies. We don't care about latest and greatest technology. This is not an iPhone. Nobody cares about if it looks cool. Okay, so how do we get over that challenge? I swear in my son's name, we actually went to Zarlink Incorporated, a microchip making company in Sweden. We created a new chip called ZL702. I ordered its creation from St. Jude Medical as a clinical director. And I worked with them, and this was kind of groundbreaking. You know, in pacemakers, it's the mixed frequency, MICS, we're communicating with the pacemaker and the outside world, wirelessly. In any high density profile, high density, like high lipid actually blocks a lot of the RF signals. Lower the frequency, less the attenuation. Higher the frequency, more the amount of data, but more amount of blockage. We created a 2.45 gigahertz wake up signal, okay, because that would take less power, and we put that into the Starlink chip. So the phone could send the 2.45 gigahertz wake up signal to the pacemaker, wake it up, check the data of the patient's present system, like present ECG, and check it. We created a new chip to make it. So we're not the kind of people to cut corners. When I'm showing you the data, everything is validated. When I'm saying 30.66 petabytes a year, we have the data from AIMS, and we are not looking at data from Australia or United States or London. This is Indian data. Okay? And I'm giving a very conservative view, 15 years life cycle, lifelong of a patient with a heart disease. Well, I'm assuming he dies at 65. I'm assuming that, well, I'm not talking about the 400 public hospitals in Mumbai. I'm talking of 30 hospitals. And these are the estimates I'm giving you. And even then you can see the numbers. So whatever I'm showing you is based on reality. And whatever we're giving you the algorithms, I have, like I said, multiple times 50 to 80 pages of authentication. And here they are, actually. It's on this computer right now. This, by the way, is your Maharashtra government presentation for HMIS. We look at page 31, I think, 31 or 22. Data storage availability on basis of above statistical data, approximately 25 to 30% growth in each year, compounded annual growth rate. This is your Maharashtra government document. And if we look at this is your evidence as to what kind of these are all your papers. All the titles, the references, where you can find it, download it, and check. Whatever data we're giving you is completely 100% authentic. 56 or 80 pages of it. 58 pages of it. So, you did a lot of work on this. So Dr. Mora, do you have any thoughts? Well, how do you feel about CardioSentinel, sir?
It is a good one, but it will need more time to understand.
Okay. So, is there anything that I can show you that would what more information do you need? I can talk to my people at Purdue and get it for you.
Not doing practical scenario.
So essentially what we're saying is that we're going to do a pilot implementation in a couple of hospitals in Mumbai, KEM, JJ, Cooper, Sion. And for that, so that you guys can take a look at how it looks. And if you like it or not, then we can go for rollout in major hospitals. So that is what I want to give to Sharad Ugade and to the Vivin Sharma. So if I can get a letter from you guys as to your opinion about CardioSentinel from what you've seen, I would really appreciate that, sir. Is that something that you guys can give me? I mean, like the letter that came from LTMG, here, madam, so we have the letter from LTMG to show something like this.
What of the margins?
Well, when when we had when we presented to KM Hospital, yes, when we showed it there, the feedback we got from Dr. Lajiva was that we have the HMI system to be able to view the images. So the feedback we got is like take a look at HMIS and how that would factor in over here. So the thing is, I think there was a bit of a misunderstanding because CardioSentinel is not an image viewing software. We are not here to show you an image. I think there was a misunderstanding by Dr. Lajiva, and I sent a letter to the dean, and I talked to the academy dean, Dr. Amit Hawle, and we have subsequent presentations lined up for like next week, and we're going to talk more with them, and Dr. Mahajan is going to be a part of it. So we do not have a definitive answer from KEM, but we have definitive answers from Sion Hospital, from JJ Hospital. The reviews are astounding. JJ Hospital is a part of the Maharashtra government, and that is going to the Director of Medical Education Research. The Joint Director, Dr. Sudhir Medkar, who was the dean over here, is right now the Joint Director, and he's heading up that panel. And the Commissioner of Medical Education, which is Mr. Anil Bhandari, he is reviewing, Dr. Anil Bhandari, he is reviewing it. So that is also going on great guns. We have had amazing reviews from everywhere, but there was this hiccup, and that's why in today's presentation I focused a lot on the image, the compression versus the digitization, and that CardioSentinel is not something that we use to view an image. Sorry, we do not compress images, we don't do that. Our paradigm is completely different. So yeah, we have to clarify that with KEM. But I'm looking for something from Cooper. If you guys like it, you guys like it. That's your opinion. If you guys don't like it, you guys don't like it. Period. So do you think we could get a letter like this from you guys? From from the.
So let them discuss amongst themselves and let the team madam also come.
Okay.
She is on leave right now. So they will discuss with the team and they will give a feedback to her, and then we will see whether we can do it.
Okay, and do you think it makes sense to present it to Dr. Shandra Chai?
No, I think they are the experts.
But as regarding HMIS and everything else, the administrative part of it, that is an important decision to be made at the top level, right?
Yeah. So I think we should wait till next week.
See, basically the integration and everything that higher authority will take care.
Yeah, exactly.
Yeah. Our job is that
Whether
okay.
we like it or not. That is.
We like it, whether it can be implemented, it will be useful. That is my role to tell you. That it is going to benefit our patient. That is our role. Once that we tell the higher authority to higher authority, then we will take a call.
Internal discussion.
Okay. Well, if you guys want, we have some. Would you like the files on it, like what we talked about? What we just presented.
Yeah, okay, same present.
Yeah, just for your reference, in case you want to.
We should have. One should do.
No,
Because I will
no.
see. It's okay if I give you an
Yeah,
example.
right,
Yeah,
for you.
otherwise,
Yes,
It's the same presentation.
Yes.
same frame. So,
How do you? I mean, just a gut feel. How do you like it? Do you like it?
it's good. But see, we need, whatever we are saying on paper, whatever you have presented, the data is from AIMS and everything. But we need to check for the how practical it is, how beneficial it will be. So what I feel is at least 6 months of a pilot project where I said that I want to have a longitudinal follow my patient, whether they follow, they don't follow, whether I have that data for 6 months. Once I am sure, okay, fine, I have certain data which looks good, then I can think, okay, fine, this should be implemented and should be done. That's all.
And I agree with you 100% because, and this is exactly like I said, we are going to the leadership in MCGM and saying this is pilot, this is not rollout. So if you guys think that this is something worth investigating, let us know and we will do the pilot, like I said, in 3 hospitals. you want to keep it?
No.
When we go,
It will help, sir. It will help in terms of you will get the old reports. What were the old reports? What was the HbA1c previously?
you will have a trajectory.
What was the HB previously?
Yeah.
What was the TLC count? With this, in that case, it will be useful. If you, as you are telling me, by just clicking on HbA1c, you will get all the HbA1c.
For me, if I'm looking at an interstitial lung disease patient, if the images are there and AI digitized images are there. So now I'm looking at, let's say, a patient in 2026, what is HRCT findings? Okay, images. Then I'm looking at 2027 and 2028. So I know what is happening to the patient. If that patient is not having any links as misplaced, and if there is in the system, now what the problems we face? The CT has been done some 2 years back, he misplaced them. He doesn't have the plates misplaced, he doesn't have the DVD, nothing is there. But if in the system, I could retrieve that. So I know. So what happens for me is diagnosing like ILD, which type of ILD, whether you have an SFT, that is core. So initial changes, what has happened in the CT, that sometimes will help you in confirming the diagnosis, what I am doing.
You got it. You
that is
got it.
what I would, from my point of view, from my discipline, it will be. Right. Sometimes we don't have, they just come in the end stage with CT, and then we don't know what I am dealing with, whether this is the cause or this is the cause. Because everything is scarring, everything is fibrosis, I don't know how it began. So if I can have an image which AI digitized where we have something, then with it, that is it.
Exactly, and then the same thing with like with angiography and and things like that. I'll let you say more on that. Like from what I have seen, like what feedback I'm getting from other places is that seeing that over time and not relying on the patient to bring the data and having it on your screen at the same time over multiple years, that is mind blowing.
One more question I had, that question. Permit from Goyal our CT is done. Okay, permit from Goyal that is from angio has been done, CT permanent. It shows a block. Okay, that's the thing. Now it is not being reported. It's an emergency, it is been done. I am not available to look at the images. If those images through HMS and digitized, whatever you say, will it pick up the blockage?
Yes, sir.
Yes.
Not only that, you have an app on your phone.
Yeah.
Your assistant can tell you.
Yeah, so
hey,
my resident will be able to, okay, fine, there is the lesion. You need to do something actually for this patient. By the time the report and everything, the provisional report will take another 1 hour or let's say 45 minutes because that images will go to the radiologist in the night when he will see and then the provisional or report will come. So it will take 1 hour. So in this case, just hello. Unclear.
So, in a situation where there is like a very sudden catastrophic event that your resident has observed, and he wants your attention. So this, the HMI system which is there in the hospital's computer is also on an app. So he can just like ping you on your phone and say, hey doctor, I really need you to like look at this right away. And you pick, I have a working app on my phone. You pick up the phone and you say, what is the health, your resident sends you on WhatsApp, this is the health ID. Click on the health ID on the CardioSentinel app. You get his entire history. You click on, for example, the angiography. Hey, there is a blockage. I need further investigation of that. So this makes emergency care and multidimensional review by senior physicians completely accessible and easy. I'm going to show you the app. The app is essentially the same thing. Like when you see the dashboard, it is the same thing except on the phone. So should we wrap things up?
Yeah.
It was a pleasure. Like if I could please have your business cards, I'd be so grateful.
See, we are in a public hospital. We don't have a visiting cards. What we have is our ID. That's it.
Okay. If I could please have your contact information so that I can connect you to our Purdue net and just let me go get one second. Sir, if you could please write your name and your phone number, I'd be very grateful. And your email address.
और सरकार ने
Right.
हाँ बघितलं नाही
So are you an assistant professor here, or are you going to stay in India or leave it?
No, I'm gonna say,
Huh?
staying in there.
Because two of the doctors at LTMG, Dr. Ishwaran and Dr. Saurabh, they're probably going to leave by the end of this year. Most people.
People who does in India.
Hmm?
Even in India, who does. Population in India.
Okay, Dr. Kaushik, this is your name. Nice meeting you, nice presentation. Okay.
Yeah, but then, like, you know, when my daughter died in 2014, when I came here to start a company for infant health, I talked to Ratan Tata, I talked to a lot of investors, and they laughed at my face. They said, हमारे बच्चे तो gastroenteritis और dengue malaria से मर रहे, तुम कहाँ कर सकते? We started the company because
India will be some way or the other. We will.
I think like right now this company can have a huge impact. Like, you know, the emergency. My father in 2018 October had a stroke. I recognized the symptoms. I had a CT scan done. I confirmed the type of stroke. Got him a tissue plasminogen activator injection within 20 minutes of it. So there was zero brain damage. Absolutely fine. And another relative had a stroke later that month. They waited to go to the hospital the next morning. Emergency response. Timely care is
Yeah, time is it.
Thank you
Thank
so
you.
much, Dr. Mohan.
Thanks.
Such a pleasure. Thank you so much. Are you with medicine? Okay. Thank you. Thank you so much, Doctor. Pleasure meeting you. So this is your colleague's pen, but this is Dr. Moore's pen.